Welcome to our video. This is the first of a series which will eventually be in our adult ADHD course. So topic 1, just an introduction and what is ADHD. So first, just a few thanks. I owe a lot to my students over the years. High school, some primary and tertiary students. Also my fellow staff who were adult education students in my class, and who in many cases let me see inside their own classes. A wonderful experience at times. And my own family. Thank you very much. The fine print. I'm not a specialist. I'm very interested in knowing what we need to know about this, but just to say this is not a substitute for specific medical advice in relation with a good health professional. So that's the standard disclaimer. There are notes and references on the website. There'll be a lot of books that I will mention. So ADHD, where do these 4 letters come from? This is a timeline I've discovered. If I Google, back in 2002, ADHD was referred to as an abnormal defect of moral control, and it's even back earlier than that. 1938, Benzedrine, which was an amphetamine, sold under the trade name Benzedrine, an over-the-counter medication that was there for treating nasal congestion. And they discovered it helped people who were hyperactive, who had ants in their pants. And this was the first written up sort of medication. The next medication obviously was Ritalin, 1955. It's a long time Ritalin has been around. Then 1952, there's this book. There's a copy of the book. It's huge. It's called the Diagnostic and Statistical Manual. And it's an American publication that basically lists everything that can go wrong with us in terms of our mental health and those kind of things. So edition 1, 1952, no mention of ADHD. Edition 2, 1968, it was referred to as hyperkinetic reaction of childhood. For 1968, it still seems a bit of an old-fashioned term. Moving on, 1980, the first time the letters appeared. ADD, attention deficit disorder, and ADD plus H. The H being hyperactivity, and that's DSM, the manual number 3, edition 3. There is a revision, 1987, when ADHD first was written up in this book. Moving on, the criteria were tweaked, 2000, and they were also fine-tuned subtly again in 2013. Just a note that from the DSM, these last 2 editions, it is specific. The symptoms don't go away when children become adults. So that's where we're at today. We're looking at adult ADHD, just where it comes from and thinking about it. Oliver Sacks, a famous writer, neurology's famous word is deficit, denoting an impairment or incapacity of neurological function. Terrible term for this thing. And if we look at the manual in the latest edition, there are 3 types: mainly inattentive, mainly hyperactive, and what they call the combined presentation. But there is much more. Impulsivity, I'm going to add in there because it's almost always somewhere in the description or the model or framework for talking about ADHD. But there's okay. So moving back now, this next little bit is my story. I first came across this in 1983. I had a student who was having some real difficulty at school, and he was given a get out of jail card. He could at any stage when things were getting too much for him show his card and come to my class. He would sit in the back until whatever it was going on died down, he's back to normal. And I had no conscious understanding of anything about this at the time. I had no language or mental model to deal with these issues apart from the button method, which was a workshop I went to which looked at teaching with a type of therapy. It was only years later that I learned the terms autism and ADHD and so on, and I looked back and I realised a bit of what was going on. Fast forward to 2006, I was tutoring and I began to get a sense of some of this. I first heard about ADHD, ADD. A little bit later, 2010, the wonderful Julia Ruckledge, the University of Canterbury, I took part in a year of the non-drug micronutrient ADHD trials, being poked and prodded with questioning pretty well every week for about 10 months. And she's written a book which I'll refer to later on. Lots and lots of pills. A little bit later on, I was teaching adult educators, and this became, I think, at least a medium level part of my course. I was looking at the three main areas of dyslexia as a neurodiverse condition, ADHD and autism. I made some dreadful clangers at the time, mislabeling, imputing mental illness, conflating conditions, stereotyping, and I probably put forward views that were actually wrong, or at best unhelpful. And I was completely unaware at that time of the debates and advocacy around attitudes towards neurodiversity, autism in particular, but right across the scene, and I did not much know about labelling. In 2022, from then on till just recently, I've had the privilege of running a few workshops with tutors and being in classes with tutors and considering the question of what do we need to know to work with, let's say, Youth Guarantee, older teenagers and young adults who have neurodiverse conditions. So that's a little bit about my story over the last few years. Now, we've had the DSM definition, but this often is very slow and doesn't reflect what's going on in the rest of the world. So beyond the diagnostic and statistical manual, we have several points. Number one, time blindness, often tied with the idea of hyperfocus, very strongly connected with ADHD. Outside America, emotional dysregulation is very strongly linked with ADHD. Or executive function. Now, executive function is a term we'll look at later on. It's the attitudes and processes we use to manage ourselves. Rejection-sensitive dysphoria, hyperarousal, and PDA, pathological demand avoidance. Pretty grim list, but there is hope, and we'll consider that along the way. So I'm going to finish with a final statement. Despite advances, there is still debate over ADHD's classification as a neurobehavioral disorder. In other words, there's something in your brain and your thinking processes that comes out as ADHD. And this is due to the overlap of its symptoms with other mental health conditions, all sorts of things, depression, anxiety, and also the lack of a definitive genetic or neurological marker. Now, I have highlighted the word definitive. What we're saying at the moment is there is probably debate about whether there are differences in our brain chemistry, like pathways, sizes of the various lobes in our brain, etc., or whether there's a genetic marker. We haven't found a genetic marker yet, but we probably have found neurological differences in the brain. All right, that's it for now. Thank you very much. Coming up in the next session, we'll be looking at coaching. I've decided a very positive place to start on this rather grim list of aspects.